I'm Peter Block here in Washington, D.C. at ACC 17, and with me for this wrap-up on day 2 are two friends. Way on the left, Deepak Bhatt from Brigham and Women's, and in the middle is Kim Eagle. I was going to say it, but I'm not going to.
You can't say it.
No, on both sides of us, Kim Eagle from the University of Michigan. Short version here is that we have 5 trials to talk about for this wrap-up. So I'm going to ask Kim to start this off. So Einstein choice, Kim, Rivaroxaban and Aspirin long-term for DVT. What's the bottom line on this trial?
Bottom line, this is a study that looked at a large number of patients who had already been treated for a DVT for 6 to 12 months. You're sitting there deciding, should I continue an anticoagulant, and if so, should I use aspirin or one of the newer agents, like in this case, Rivaroxaban. In this study, continuing Rivaroxaban for a year compared to aspirin was more successful. There were less events in the patients on Rivaroxaban and no more bleeding, frankly. So our patients who are in this situation where we're thinking about extending therapy, this trial really suggests that Rivaroxaban is the choice over aspirin.
So Kim, you say River, I say River, but the bottom line is, what's the dose that is really appropriate here? Because it varies in bleeding, doesn't it?
It does. The 20 milligram dose in this trial had more nuisance bleeding than the 10 milligram dose. The major bleedings were fairly similar. But if you're worried about bleeding risk, certainly 10 milligrams appears to be adequate.
And that's a reasonable dose of Rivaroxaban.
Absolutely.
Rivaroxaban, whatever it is. Okay, let's move on to coronary work. Deepak is our interventional cardiologist. 3 trials put together as a group. We have Compare Acute, Defined Flare, and IFR Sweetheart, the last being particularly dear to my heart. So, Deepak, talk to me about these 3 trials.
Sure. So thematically, they're somewhat linked. They're important trials, all came out simultaneously in New England Journal of Medicine. So as far as the Compare Acute, that was looking at non-culprit lesions in STEMI patients and found that an FFR-based strategy of revascularization significantly reduced the rate of MACE. Now, that was largely driven by repeat revascularization, but directionally, death and MI were going in the way you'd want, not statistically significant, though.
So let me just ask you a question, because
Sure.
I've been doing this for a while, and you've been probably doing this for a while as well. Somebody has a really tight diagonal lesion or whatever, and their LAD is occluded. You do the second one at the same sitting, or at least I've been doing that recently. This sort of supports that, doesn't it?
It does. I mean, obviously with these trials, there's careful inclusion and exclusion criteria. You know, if somebody's creatinine is 2.8, that might not be the time to start chasing non-culprit lesions. But in general, it seems like a good strategy. I'll point out that there is a larger trial that's going on, the COMPLETE trial. It's larger than all the previous non-culprit trials put together, that is powered to look at death or MI specifically. But at least for Revasc, it looks like the COMPLETE Revasc strategy is a winner. The other 2 trials were not STEMI. They had some non-STEMI patients, were mostly stable angina, Defined Flare, IFR Sweetheart. These were great trials, very concordant findings showing that IFR, the instantaneous wave-free ratio, versus FFR, fractional flow reserve, was non-inferior. And people might say, oh, why does that matter? Actually, it's a big deal. I mentioned in the accompanying editorial, in fact, that I think it should change the standard of care for invasive assessment of lesions, because IFR is easier. You don't need to give adenosine. It's quicker, less patient discomfort, faster procedural time. So to me, if one is choosing between the 2 strategies, if they're equally priced, IFR is a clear winner. But you've used it in your lab. What do you think?
I use it at the VA where I work on Thursdays, and candidly, I like it because it's so quick. You know, you just take a look at about 5 or 10 QRS complexes and pressure curves, you've got the answer. Now, my problem with it is that the confidence intervals are a little close to 100%, right? A worrisome IFR is 0.89 or less.
That's correct.
But 0.93, you start to say, well, really, should I check it? The good news is you can just go ahead and check it with a real FFR.
Yeah, if you wanted to, but I would actually counter that the IFR that was used, corresponds. There's been an upward drift in FFR, right? We all use 0.8, but the older classic studies, it was actually 0.75. But at any rate, I think this IFR value of 0.89 or less is the correct value when one is using IFR.
Yeah, and you can always, repeat it if you need to, and get the answer.
Absolutely.
that
I mean, it's
you
clever.
really need.
It's looking at flow during diastole. Right?
The interesting thing about that trial, Deepak, is that patients that had the IFR had fewer stents placed than FFR patients. And that's a big deal because their outcomes were better.
Yeah, it is a big deal. And there are cost implications to that, too, in a good way. Potential healthcare savings.
So less is better sometimes.
Well,
and the eye test doesn't work. You need to measure flow.
That's right. It keeps us
Okay.
honest in the lab, right?
So did
And we
say,
want to do that. For
Did we
sure.
say anything about defined flare? Did you mention that?
Well, defined flare and IFR sweetheart, to me they're a pair
Okay.
because they're both very well conducted trials and very concordant, both showing non-inferiority of IFR, but in a sense you could say for these secondary endpoints, superiority.
Actually, both of those trials were put together by the same people. It's sort of an interesting collaboration. Okay, let's move on to Ebbinghaus. Cognitive Outcomes, a 4-year trial. This is the biggest trial probably at this meeting, the PCSK9 inhibition and the incredible changes that you get with low LDL. What happens to your brain, Kim?
So that's been a big question mark. If you lower the LDL under 30 for very long, what happens to cholesterol metabolism and brain function? Ebbinghaus studied about 1,200 patients and studied them carefully with 3 different batteries to look at cognitive function. And at least at 20 months concluded that there was no clear signal of harm to cognitive function on the PCSK9 evolocumab. So I think we can be reassured, at least for the short term, that we're not seeing a major signal here.
Yeah, we're not going to get Alzheimer's in 12 months.
No, or 20 months. After that, I can't remember.
Okay, fair enough.
What was the question again?
So we're all taking PCSK9 inhibition clearly. But
Well,
in
I
any
can't
case,
afford it myself.
Thanks, folks. That's a wrap up for day 2.